as well tonight. They're focusing on the key issues facing the sector. And the first one we had here not that long ago was to look at CCTV in residence rooms to improve the support and security of residents and staff. And I see a familiar face out there tonight as well, so welcome again. Now that was a really successful event, and I think what we realised is that everybody involved in this sector wants to see improvements. That's why we've got a Royal Commission. But I think the thing we're a little bit worried about is that in the midst of this election, nearly every advocacy group has been saying not enough has been done in terms of the election. I can see your heads nodding out there. So tonight we're going to push on and ask what we can do better. And this final session that's going to come up in June will discuss the issues of quality and compliance as we move into a new era of regulatory control. But the session tonight is going to focus on the issues of mandatory staffing levels versus a flexible model based on matching skills to assess needs of residents. Now, when I've seen some of the petitions out there, everybody seems to jump immediately and say mandatory levels are the things that they want. But for people that work in the sector, they have other views, and we should always have an open mind and hear the arguments. So I think we'll hear some of those tonight. The other issue that we're focusing on tonight is the issue of training the current and the future workforce. Also the role of the nurse practitioner in aged care. And we're very pleased tonight to have with us Rebecca Sharkey, the Federal MP for Mayo in South Australia. And Rebecca currently has a bill before the Parliament, the Federal Parliament, calling for the mandated publication of staffing levels quarterly on the My Aged Care website. We also asked the opposition shadow spokesperson, Julie Collins, to come tonight. She wasn't available, and we also asked Ken Wyatt tonight, the Minister. They weren't available. But I do note, Rebecca, that the listing of the staff is something that Labor has announced only on yesterday at about 11:28 a.m. So that is going to be something that we can talk about tonight. Also, we've got Moira Noonan, the Chair of the South Australian Network for the Australian College of Nursing. Thank you very much. Rob Bonner, Director of Operations and Strategy with AMNF, and that's the Australian Nursing Midwifery Federation. Dr. Rodney Gilek, Principal Consultant with Aged Care Advisory Services. Now, any discussion that affects the outcome of future staffing models, training and requirements and skill levels must be achieved through bipartisan approaches, and I would say multi-partisan is the word we're looking for. In other words, we want everybody to be behind this in the same way as when we talk about strategies addressing child abuse or youth suicide. I think, you don't want politics to be in it, you want the best possible outcome, and that's what we're calling for tonight. And we're calling for that not just from the political parties, but also the unions, the training institutions, and all of the other people involved, and that includes the staff and the families and the consumers, as they like to call them these days. I still like to call them people, but they're consumers in the new world order. And Aged Care Management Australia believes that we've lost our way in training our professional nurses and our carers. So these are Peter's words now. This is what he believes. If he was here tonight, he'd be saying this. There is insufficient focus and exposure to the practical application of managing residents with dementia and associated behaviours, or in the management of palliative care. And I think that is absolutely critical. I have a personal story to do with both my brother and my sister-in-law to do with palliative care, and I do believe we can do much, much, much better. That's not a theoretical comment, that's from first-hand experience in the last couple of years, and I'm hearing more of that. I'm hearing there are good things happening, but we've got to do better. Now, this is particularly so in the training of our Certificate 3 staff. We're letting this group down by failing to prepare them fully to meet the needs of residents. Peter continues to say that many of the current online quick fix training courses are being run the advantage of the RTO, the Registered Training Authority or organisation, and it doesn't meet the needs of the student or the industry. In the debate over setting mandatory staffing ratios, we have strong calls from the community and from the AMNF in support. Equally, we have strong concerns from industry bodies and providers that the cost of having these mandated staffing levels is cost prohibitive in the current funding environment. And this model will also create severe pressures on regional and remote providers where attracting and retaining quality staff is already problematic. ACMA, Peter's organisation, believes the answer lies somewhere in between both views. And I've had discussions with Peter about this, and I know that that's what he wants us to do. Look at both sides of the argument, assess the argument. And remember that the word argument doesn't mean yelling at each other, it's actually a proposition that you put forward and you consider. And it's wonderful that we can do that tonight. Now, ACMA says we do not support the simplistic approach of having fixed mandated levels. There is sufficient Australian and international research to indicate this model is not effective. The Productivity Commission doesn't support such an approach, and it labels it as a blunt instrument in a complex environment. And I think that word blunt instrument has been used a lot. It's a very common criticism of the approach. In order for the future aged care workforce to be successful, then we have to address the following. Peter's words again, undergraduate nursing studies need to have greater allocation of both academic and practical time for the student to understand the complexities of managing residents with behaviours, dementia and palliative care. Certificate 3 training needs to return to the classroom and to return to an apprenticeship style training where skilled nurse educators provide the teaching and where we have minimum entry requirements including the ability to read and write in English and to have assessed pass and fail criteria. A little aside, I watched Four Corners last week and they said there were people coming into universities in Western Australia from some regions of India, and they sat there a bit like Manuel and went, okay, in the interview. They didn't understand any of the questions that were being put to them. And the academic staff said they were virtually putting their jobs on the line because they were so concerned. If that's happening at the university level, then I think we should be very concerned that Peter has raised this here, and then we'll get to that tonight as well. We need to address the wages of our carers and have recognition of training outcomes. Once we have this part of the model established, we need the following. A flexible, highly skilled workforce that has sufficient numbers to meet the assessed needs of the resident group. We need the current review of aged care funding to include a review of governance and how public funds are spent. Providers must be accountable to the government for how subsidy funding is spent and if it's not spent on staffing and the cost of care. Now, this is something that Peter has, which I think has made an incredibly brilliant point here. You think about this. The provider must be accountable to the government, in other words, the taxpayers, on how the subsidy funding is spent, if not spent on staffing and cost of care. In other words, we need to know that figure. How much is actually spent that gets to the person who's being cared for, and it's our money. The federal government must be creative in the future use of accumulated RADs. Now, does everyone know what a RAD is? You look a bit blank. Do you know what a RAD is? You don't. Good. I didn't know until I heard that jargon as well, but it's a residence accommodation deposit. Refundable accommodation deposit that the resident provides to the aged care provider. And if you think about that figure, and if it is in the hundreds of thousands, which it is, and there are hundreds of thousands of people in aged care, then you have hundreds of millions of dollars in RADs. You're good at maths, I know that, because you're a computing man, aren't you? Yeah. So you've actually got, now this is incredible because the federal government must be creative in the future use of the accumulated RADs, the bond holdings, in other words, what they're doing with that money. Perhaps a percentage of each of the facilities. So in other words, if you've got an aged care home with 100 residents and 100 residents have paid $300,000, there's a lot of money sitting there in that account. Perhaps a percentage of each of those could be set aside to fund education and training. Peter's suggestion is an amount of 1.5% of the accumulated RAD holdings could easily fund sufficient training regardless of the RADs held. There's currently approximately, wait for it, $40,000 million being held across the country in RADs. $40 billion is sitting there. 1.5% of this is a big number. Someone could perhaps work it out for us. 1.5% of 40 billion, and that could be used to support future training and labour force management. Interesting concept to discuss tonight. Finally, the role of the nurse practitioner could be used to achieve greater outcomes in supporting residential care facilities and home care providers in a range of specialities, particularly our regional and remote and Indigenous communities where access to GPs is either limited or recalcitrant. Specialities in the support of behaviour management, dementia care, palliative care, medication management, infection control and wound management. So these are some of the things that could be done by the nurse practitioner. In closing, Peter would like to recognise our views may not be in line with others, but I respect the need to be able to express our views and those with opposing positions in a professional and meaningful debate. And he wants to say that our next forum will be on Wednesday the 12th of June, and it's going to be about compliance. Have we got it right? But I think Peter's given us some amazing things to think about there, and also I love his way of solving problems, because people often say, all right, where's the money going to come from? And when you go to government and they say, well, what's your ask? And they say, well, how am I going to pay for it? He's actually given us an opportunity there to think about. And I hope that whoever wins government does think about the issue of training and having dementia training and having better training and having better paid and better trained workers, because we all agree on that. But look, we're going to go through a Q&A. We're going to have the opportunity for you to ask questions in a moment, but I would like also to basically give each one of you an opportunity to say your point of view. And Rebecca, we'll start with you, because you've managed to put this bill into the Parliament. You've managed to get some movement on it, because the party that it's being predicted to win by, it's like the Melbourne Cup. Who's going to win the Melbourne Cup? I think it's probably a bit easier because it's a two-horse race, really, unless you count Clive. And I'm not sure. He says he might be the next Prime Minister. But whoever is in government is going to have to look at that bill that you've got there. Now, where's the bill at the moment? And you're not wanting mandated ratios. You just want to be able to say, when I pull up outside the Bupa Aged Care Home in South Adelaide, I want to see whether they've got a nurse practitioner, a registered nurse, an enrolled nurse, and how many carer staff are in that home where I'm going to put my mum or where I end up. I want to know that. And that's all you're asking for, isn't it?
Look, basically, yes, on the My Aged Care website, that every aged care facility would provide details on their staffing ratio mix. It also gives an opportunity for each provider to detail why they have that staffing mix. It could be that they have a nursing home that is a very spread out facility, an aged care home that's very spread out. They might have a higher expectation of patients with dementia needs. So that's the purpose. It's around transparency so that we can then get the best policy outcomes. Because at the moment, we have no idea who is working in our aged care homes, what their qualifications are, and there's a very wide variance on the percentage.
Can I ask you just on this though, because
Yep.
I know you get around your electorate and you go to
Yes.
various places. You would have no doubt been pulled up at some point by someone in an aged care home and said, what do you want about Rebecca? And
absolutely.
how's it being received?
Look, my community is well aware of this. This actually came from an elderly gentleman in my community. Mayo's the oldest electorate in South Australia, so I'm very well aware of a number of issues that affect older Australians, and this is one that I think is very much at the heart. For many people, even if they're not necessarily older themselves, the trust is put in them to find a good place for mum or dad, or indeed their partner. I will say where the bill is at, or where it got to before Parliament finished. So the bill went to an inquiry, which is quite unusual for a private member's bill. And even more surprising, the inquiry the committee came to the conclusion that the bill should be passed. When we last left off in that last couple of weeks, the Minister, Ken White, advised me that he had personally written to the Prime Minister asking for the bill to proceed.
Okay, so you've got the Prime Minister and you've got the Minister for Aged Care on side. You've now got the Labor Party coming out on the weekend and saying they're on side, so... Well, I can say we can just about cross that one off the list and say, well, that's there.
Absolutely. Look,
now, some people see that as the first step in mandated ratios. What's the answer?
I think it's the first step in improving this whole policy area, because I think it's just looking at mandated ratios, I think is quite simplistic. We need to look at where we're going to get the workforce from, and I think a lot of the issues that you raised, that Peter spoke about. I mean, really, we need to. I think we need to tie future aged care funding to staffing. I think there needs to be a percentage that's tied to the two, because it seems that we give, more funding for aged care, but I'm not necessarily confident that that then translates into staff on the ground. I've also spent a lot of time talking with aged care workers. They're exhausted. We know a very high percentage are looking to leave the industry within 5 years. This is incredibly hard work and yet incredibly important work. So I think it's a very complex policy mix that we need to get right. I also want to see this as a career that is attractive to people, and at the moment it's not. The pay is not good. It's incredibly hard work. People who are moving into aged care facilities now are more frail than they ever have been before. So I think we need to have a look at all of the aspects. However, transparency in who is working in facilities, I think, is a very good first step to get it right, because how can you determine what the staffing should be, what I guess best practice looks like if we have no idea who is working where and what their qualifications are. There's no requirement in South Australia to have a registered nurse on the floor. You just need to have access to...
I think that was another thing that came out from the Labor Party on the weekend, was the call for a registered nurse to be in an aged care home 24 hours a day. So, I suppose a lot of these things are happening, but that brings me to...
I might just end with where my bill goes from here. At the end of every Parliament, basically the slate is wiped clean and you start again.
Oh, really?
Yeah,
so,
absolutely.
So your bill's just...
No, well, we can just pick it up and bring it in again, because whoever is the government of the day, it's my job as a person sitting on the crossbench, this is assuming I still am employed and I go back to working on the crossbench, to make sure that we get it right. So I will be in the first available week reintroducing my legislation.
And then you don't have to start from scratch, you just reintroduce it.
We don't have to start from scratch.
That's
we
good.
Might tweak it a little bit based on what the committee said, committee's findings, and keep pressing from there. It's about making sure we apply the pressure to get the best policy.
All right, now, Moira, thank you very much, Rebecca. Maura Newman, now, Noonan, the chair of the South Australian Network for the Australian College of Nursing. Now, Maura, tell us your thoughts on what you've just heard. You've just heard a politician talking about what her community is, but you're channeling your community.
Yeah, absolutely.
I want to know what the nursing community is saying.
So the nursing community would agree with a lot of what Rebecca has said. So we know that we've got an ageing population, and that with the focus for our ageing population to stay at home for longer, it means that the residents that are coming into our residential aged care facilities are much more complex than they have been in the past, and have much higher needs. And at the same time as we are having much more complex residents, we are de-skilling and relying on an unregulated healthcare workforce.
Well, I believe your organisation or one of the nursing organisations has got a graph where you can see there has been an increase in the number of people in residential care. There's been an increase in the number of care workers and a flatlining and slight decrease in the number of enrolled and registered nurses. So it's actually counterintuitive. With the more frailty, you would expect that there would be a more need for more specialised staff. Now, is that correct? I've seen that graph.
That is correct, and if I've got that number somewhere here, which is that the number of registered nurses in aged care facilities has fallen from 21% in 2003 to less than 15% in 2016.
Right, so it's the opposite to what you would expect,
exactly.
Isn't it?
And the complexity, for example, those that we classify as high care has quadrupled.
So we've got 4 times as many people needing specialised nursing care. Can we make that leap or not? Can you say that those people need specialised? Or could you, because I've heard the counter-argument to say, oh, well, it couldn't all be filled with nurses. You've got to have care workers because if you have more care workers and they're trained properly, they can do the job of a nurse. Now, have you heard that argument?
Yeah, and we certainly don't say that every worker in a residential aged care facility should be a nurse. What we are saying is that you require a skill mix that meets the needs of the residents.
Hey, where do you come up with that answer? Because if I ask you that, and I ask even the family of someone, and I ask the government, I mean, we're going to get different answers, aren't we?
You are, but you also have to understand that you're never going to get an exact definition of what you require at any given time because every facility is different. You will have facilities that were built 30, 40 years ago, and you'll have the latest state-of-art facilities that were built, designed around dementia principles and, beautiful...
Well, can I cut to the chase and ask you, do you think the system is failing the people that it's supposed to be caring for at the moment? Because we hear that a lot. Do you think it's failing the people that it's supposed to be caring? The system?
That the Royal Aged Care Commission is evidence that in some places it is failing. Not everywhere.
Not everywhere.
There are facilities that provide fantastic care to our elderly residents, and that's a lot of... There are no simple answer. A lot of it comes down to the culture of whether there's that culture of caring that exists within a facility, whether there is enablement of a human aspect rather than purely task-orientated care. It needs a considered focus on all of the things that impact the care that is provided to our residents and their individual needs. They need to be looked at as individuals and not just as a blanket population. The other thing that I would definitely agree with Rebecca on is that we need to value not just our aged care workforce but our aged care population. We need to be seeing working in aged care just as attractive as working in an emergency department or ICU or any place that we will find the healthcare workforce. And at the moment, it's not.
Well, that's interesting, and maybe we could come back to that too, because there are some people that say, when I say, well, it comes from the healthcare budget, it's healthcare, they say, no, it's not. That's still...
You hear the same thing in disability.
You hear the same thing. Well, look, now let's bring in Rob Bonner, Director of Operations and Strategy with the AMNF. So let's go straight to the strategy, Rob.
Can I say that there are some things that have already been said that I agree with,
yep,
and some things that I think need to be explored. I think
and we'll bring the microphone a little bit closer too, because we just get, yeah.
So transparency of the existing staffing arrangements, I think, is absolutely long overdue, and we've talked to Rebecca often and long about her bill, and we've been very supportive of its passage. But transparency does not, in a closed market situation, which aged care is, deliver choice to consumers. If you've only got 1 or 2 aged care providers in your town, your region, then even if you know that staffing levels or skills mix is not particularly optimal to patient care needs, you still don't have much of a choice about exercising that new information. So we think that the next logical step in building on transparency is the issue of providing mandated minimums that are linked with the evidence. So that goes to the issue that Ian,
and do you have a figure on that mandated minimum?
Yeah, we do. Yeah. So, but I want to avoid giving you a single answer, because the single answer is where it gets misused into creating this blunt instrument argument that is an absolute fallacy. No one out there is arguing for a single ratio to apply across aged care. No one is arguing for a fixed number to apply on a day-to-day, shift-to-shift, patient-to-patient level. But it has been constructed as there is this single ratio that someone's seeking to impose on aged care. It's inflexible, it's not responsive to client needs, and therefore it's a blunt instrument. That's not our position. So our position is that there are broadly in our research 6 levels of care that can be identified within the aged care system, going through from someone with minimal care needs through to someone who is in end-stage palliation. Now, that's not a remarkable phenomenon. It happens in our acute hospitals every day, where there are layers of care that are responsive to the individual needs of consumers, but they're aggregated into care groups. Now, that's where we say the number has to increase from around about an average of 2.8 hours of care a day across Australia in aged care.
And what is the average now?
That's 2.8.
Is it? I've heard some people say it's 2.4.
Well,
I mean,
it depends which benchmark study you're looking at, but the broadly accepted benchmark's around 2.8.
And it should go to what?
It should be 4.3.
4.3. And do we know that because that's international, or?
No, it's based on current Australian evidence of looking at the care plans of individual clients in aged care, looking at the interventions that sit with their care needs, and then applying the timing studies to that.
Can I throw a spanner in the works here, or maybe a bit of information? But when the Royal Commission had its first hearings of evidence here in Adelaide, one of the people that got up and spoke was a professor. I can't remember where he was from, but I was sitting there watching this, glued to it, Days of Our Lives or Days of Our Future Lives. I was watching it every day. He came in and he said his piece, and the Commissioner, Tracy, sort of said, can you give us an idea of where the best aged care is and how they compare to us? Because he wanted to cut to the chase. This professor said, well, the best, as far as we can say, around the world are Holland and Sweden, and on average they spend 2 to 3 times what we spend. Now, you just said 2.4 hours and you want...
We want 4.3 as an average.
Well, the figure's coming in. It's the figure's coming in, isn't it?
Can I say to you, the biggest aged care provider in South Australia is the Royal Adelaide.
Yes.
Because 70% of its admissions are over 60. So anyone who pretends that aged care nursing doesn't occur in the acute care stream is deluding themselves. One of the things that we will get out of improving staffing levels and skills mix in residential aged care is stopping the bouncing ball of people out of nursing homes and aged care facilities.
So it could actually be an argument for
stopping the misuse in the transport,
Yeah.
stopping the need for paramedics to have to go in to change catheters in aged care. So there's enormous wastage in our system, both in human and financial terms.
Who recognises that at the moment? Anyone?
Who recognises
Yeah,
it? There's academic evidence of it, and certainly areas like New South Wales Ambulance Service have published some of their transport times that show the enormous wastage in terms of the physical infrastructure and paramedic hours. That then translates into the emergency departments and into medical and surgical wards, where people are kept, and we know that if you're kept for longer than 24 hours in acute care, you deteriorate in terms of your physical conditioning. So getting people into that whole sort of treadmill of transport from aged care into the emergency system, into acute hospitals, is just not a great idea from cost, from human outcomes, or from professional practice.
And Rob, you've got something you can present to us now, I believe?
Yeah, sure. I'm happy to.
Yeah, I'd love you to do that.
Ian.
Yeah.
Now, is someone going to click through it for me? I think that the first thing do you want me to go up to that?
Yeah, that might be
Yeah,
an idea.
okay. Okay, sure.
Anyway, have a bit of a wriggle in case you're getting too much talking. Yeah. All right.
Okay, so if we can just go to the first slide. And this really is my starting point for the comments that I've already made.
Oh, gee, that's a bit hard.
This debate is not about a whole range of things, and I think that some of the mythology that is in the argument already is about no one is arguing for single fixed staffing ratio across the aged care sector that I'm aware of, or even in residential aged care. The blunt instrument argument has been concocted by people to try and discredit the argument around mandated minimums. No one is arguing that residents or consumers or clients of care should receive the same constant or same level of care regardless of their individual needs on a day-to-day, shift-to-shift, week-to-week basis. No one is arguing that meeting consumers' needs for care must not be central to the outcome that we're trying to achieve. Missing word there in that slide of not. And no one is arguing that other things need to change as well. So no one is arguing that mandated minimum staffing levels is the silver bullet, will fix everything in aged care. I absolutely agree with some of the comments that have been made earlier, that we need to fix the compliance system, we need to fix the leadership system, we need to fix the professional development and investment in workforce. But what we would say is that the issues in aged care cannot be fixed unless we deal with minimum staffing levels and skills mix. So it's not the only answer, but it's an essential ingredient of the answer. So next slide, please. So this debate is about the failure of both the market and the existing regulatory systems to ensure the provision of appropriate numbers and skills of mix of staff to provide care. And that goes back to Rebecca's point that we've been ploughing more and more money into this system for years. Different governments at different times, but the money's gone in, outcomes have gone missing. So we have got the growth in demand and the reduction in staffing numbers and the reduction of skills mix over the same period. The evidence, we would argue, which is now beyond doubt internationally, that inadequate numbers of nursing and personal care staff required to meet care staff results in harm. So if you don't provide staff, you don't provide the right skills, you do lead to harm to residents, both in terms of morbidity and mortality across all sorts of aged care and other settings. We've got now growing evidence of missed care in Australia residential aged care. So this is care that should have happened, was planned to happen, was required by residents and is not occurring on a daily or weekly basis, which again impacts on mortality and morbidity of residents in that sector. And as I said, whether simply providing even more money, bigger checks to providers in aged care will result automatically somehow in providing improved staffing and care without these other accountabilities in place, and certainly from our point of view they will not. So we think that, like Rebecca has already posited, I think, that we have to go back to a system of requiring disclosure of how the money is spent for the purpose it was intended, that is the care of residents. So the next slide. So what do we say the problem is? So the chronic understaffing that's already been suggested, an average across the aged care, residential aged care system in Australia of around 2.8, when our own studies and international evidence suggest an average requirement of about 4.3 hours a day. Now that goes from a minimum number of around 2.5 up to around 5 hours a day, depending on the individual care needs of clients. Cuts that have been made to already poor levels and mix, and Donna raised those issues already about the sort of the inverse nature of the growth of requirements and what's actually occurred. Hardly a month goes by in our office where we don't hear another new example of an aged care provider that claims because of funding, because of availability, God knows what else, that they are not having to make cuts to their rostered hours. Now that's just normal existence in our current environment. Increasing resident aged care needs, so we know the care needs are going up and they continue to go up. And of course, there are many examples and reports of abuse and neglect. And the Royal Commission's already published those incident reports that have been provided by providers of inadequate or inappropriate care. So next slide, please. So the impact of lower staffing on levels of outcomes of care, the massive and growing evidence for association between nurse staffing and patient-client outcomes across all settings, across every area it's been studied. It's more heavily researched in the acute sector because that's where the money is, that's where the research is, but miscare is a commonly occurring phenomena in aged care and across all settings. So according to the international research, and I've left out the front and happy to send to those people online the bibliography that's in relation to this evidence. Every additional full-time qualified nurse per shift reduced the likelihood of surgical patients dying by 7%. So we're not just talking about people being a bit unwell or not recovering as quickly, we're talking about a direct relationship where every additional full-time nurse per shift reduced an increase of surgical patients dying. Every 10% increase in nurses with a degree level qualification, and this goes to skills mix on the way through, is associated with a 9% decrease in patient deaths. So if we put more registered nurse hours and more enrolled nurse hours in and reduce the reliance on care staff, not getting rid of, but reducing the reliance or preponderance of care staff, there is a relationship with the death rate of clients. Increasing the patient load of a nurse even by one, associated with a 53% increase in respiratory failure, a 7% increase in hospital-acquired pneumonia. So there's just some of the research findings that have been evidenced in the literature. Now, there is no direct causal relationship established. I just want to be upfront about that. And it's a bit like the argument with cancer and cigarette smoking. No one has done a randomised controlled trial because to do that would be unethical. So, but no one doubts the associated relationship between cigarette smoking and cancer. Similarly here, no one's going to deprive people of skills and staff that they require to get better in order to prove the relationship in a randomised controlled trial. But there is absolutely established associated relationships between nurse staffing and mix and resident patient outcomes. So our own research on the next slide established that care needed by residents was being missed and that understaffing was the most significant reason for care not being provided across Australian residential aged care. As I've said, it shows a need to increase nurse staffing and care worker staffing from an average of 2.8 to an average of 4.3. But equally critically, it demonstrated a need to change the mix of staff from the 20% RN, 10% EN, 70% care worker that is the national average across the whole industry to 30% RN, 20% EN and 50% care worker. So a fundamental realignment of the skills that we need to deliver the assessed care needs that residents have. So just briefly, the next slide, how did we go about that piece of work, which goes to your question? We analysed the care plans of around 100 residents and broke that down into the interventions that sit with those residents and rearranged those into groupings of similar level interventions that are required. We allocated the time that took to deliver care. For example, how long does it take to give an injection? How long does it take to give oral antibiotics? How long does it take to shower someone? And then we timed that piece of work, 180,000 timings in our database. So we're not talking about some Mickey Mouse once or twice we've seen it. In order to get into the database, you had to repeat that data collection 20 times in that environment. And then we allocated the skill mix type to the lowest category of staff that was able to safely do that work. So some of that work could only be done by a registered nurse, some could be done by an enrolled nurse, and some could be done by a care worker or a registered or enrolled nurse. We then calculated that out and we tested it through national focus groups and a national Delphi study, not just of nurses and care workers, but also of care managers. The study was validated by over 70% in the first Delphi study round by care managers across the country. So we have a huge amount of approval of the modelling, not just from nurses in the environment, but also care managers in the environment. And finally, in terms of this particular issue, how would the system work? So you'd use the existing assessment and care planning information to make these decisions. So we're not talking about inventing some new assessment process, we're talking about using the assessments that are already used, whether it's for ACFI or for the new RUCs or for daily care planning and delivery, and sorting the residents into those categories 1 to 6. That would then drive the allocation of the hours at a facility level over the roster. So not for that particular patient on that particular day, but how many hours do I need to meet the total number of residents, so the 80 or 90 or 100 people in the facility, multiplied by their care group, multiplied by the number of days and days of the week. Then you allocate those hours depending on what the care manager and clinical leaders are saying on a daily and shift by shift basis. So you don't fix those numbers in for all time. That gives you the total number of hours that you can roster. And then we're saying you have to audit and fund. So that goes back to Rebecca's point, which is you have to show that you spent the money for the purpose that it was provided.
Thank you very much. Conscious of that. I mean, I think we should throw it open because I'm conscious of the audience wanting to ask some questions, because at that point we were given a lot of information there, and I think it's great information. The question I think will be in people's minds is how do we make it happen? So would you like to, anyone got a question about what we've just heard? I'd like to bring you in now. Any nurses in the audience? Come on, a nurse must have a question about that.
I've got a question.
You've got a question. Rebecca, you have a question then. Yeah, go for it.
It's I'm just wondering how we build the workforce, because we know we're struggling to find people to work in the NDIS space, and I see the two, you know, it's often the same skill mix, looking, you know, do I stay at a traditional healthcare space? Do I go into the disability sector? Do I go into the aged care sector? I'm just wondering how you think we would find the staff.
I think that is a really foundational question. And I think that the answer is a bit like the childcare argument was 10 years ago, that we don't start from what can we deliver next week. We have to look at where do we want to be at the end of the reform exercise. And our view is that we've built a program that allows us to move towards those numbers and that skills mix over about an 8 to 10 year.
But we know the figures. I mean, the demographers know the figures. We know how many people, I mean, Ken Wyatt stood up at the National Press Club and said, in 2050, we're going to need to go from 360,000 workers to...
A million.
He said almost a million. Yeah. And if you look at that, you're talking about 600,000 workers in 30 years.
But
how are we going to do that?
We need to be talking about the right kind of workers, not just the total number of workers, and that's our point.
But do you think we can get there?
So we think that you do need to plan it. You do need to start work on it today. For example, we know that about half the registered nurse population in Australia will retire over the next 8 to 10 years. That's the current numbers. So just to replace that's 180,000 people over the decade. So if we want to build that number of people, whether it's in aged care, whether it's in acute care, whether it's in primary...
Well, I mean, there's an aged care workforce planning committee based in Canberra, and
there is now.
There is now, yeah.
But it needs to be focused, as I say, not just about replacing the number of people as though everyone's equally interchangeable. We need to be directed towards achieving the reform of that workforce over the period. So that means we need to produce more RN graduates, we need to produce more enrolled nurse graduates, and we need to improve the capability.
Or we might do what we did in we might do what we did in the 1970s, which we brought them all in from Canada and England when we were a shortage of teachers. Remember
Except
that?
they're grappling with exactly the same problems.
Yeah, I know.
And so they're now, you know, especially in Britain, faced
I know
with the
that you can't.
European
You can't. It's not going to be possible. No.
Precisely.
I'm very conscious of making sure that all our speakers get an opportunity. Now, Dr. Rodney Gillick, would you like to give your? You've got a presentation as well. Yes. Well, you can have your presentation. Yeah.
And this presentation echoes a lot of what Rebecca and particularly Rob have already said. But if I can have the next slide, what we really see very much the issue is two questions are posed by this whole idea of mandated staffing levels. Do we actually need mandated staffing levels, and or is it another mechanism to make sure that we have the right numbers of skilled staff? And will a mandated number actually work? And what we're suggesting is that, based on our experience, a mandated number actually doesn't work. It doesn't make any difference, and it doesn't have the outcome of improved care. If I can just have that second slide. Because basically in New South Wales, we've had through the Public Health Act mandated staffing levels for almost 30 years now. So the Public Health Act and the Nursing Homes Act prior to that said that we need to have a registered nurse 24 hours a day, 7 days a week in aged care services. And the mandated level that they decided on was 1. So it doesn't matter whether you have 10 residents, 50 residents or 200 residents, to meet that requirement you need 1 registered nurse. And clearly 1 registered nurse is not enough to provide care for such an enormous group of residents. But what we now see is homes that meet those requirements but have 1 registered nurse looking after 80 residents, 100 residents, 150 residents. So while they're meeting the minimum standard, we're actually not getting the quality care that we expected to achieve by mandating a number. And if I can have the next slide. The main reason for that is because obviously providing aged care services is an extremely complex task in itself, and there's a whole range of variables that you need to consider. The number of residents, the assessed care need of residents, expectations of residents and relatives is a huge thing. The physical environment, capabilities, qualifications, training provided, the leadership of the organisation, the culture of the organisation, the systems that they have in place, and even the equipment that's available for the staff to use. So we're looking at something that's far broader than just an arbitrary number that someone comes up with that says this is what's required. If I can have the next slide, what we see currently happening is a huge disconnect between what people want and what we, and I use the term we because the majority of funding for aged care is coming from taxpayers, can afford or are willing to pay. So what has really been lacking in a lot of these arguments for years has been an independent study, and I know the AMF have done studies looking at the number of staff that are required, but looking at how much it's going to cost to meet the expectations of residents, their families, the regulatory agencies, and actually coming up with a figure of what it's actually going to cost. And what we'd really like to see is that review be done by an organisation that's not beholden to the sector or the unions, sorry Rob, or the government, because when we have these studies done by these organisations, everyone else says, but that's the nurses' union's stance on things, that's the academic organisation's stance on things. If KPMG does it, they don't want to risk their funding from the government. So it's about having someone independent or a group of people undertaking this to look providers is that they're underfunded, and I can say as a provider, working for a provider and being a director of nursing, it is very, very difficult to provide the highest quality care consistently with the money that is available day to day in the sector. We hear that the government has no more money to pay. We know that taxpayers don't want to pay any more tax, so there's a smaller pool of money. But everyone wants higher standards, they want more services, they want more staff, they want better quality, but no one's really wanting to pay for that. The other alternative is very much what Rebecca has proposed, is the publication of actual staffing levels. And we work with a lot of providers that are really, really happy with that initiative, because not only does it put everyone on a level playing field, but what it does is it provides an opportunity for those providers who invest in staff and have more staff to actually stick out from the crowd. So they're not seeing it as a basic level, oh, this is what we're going to meet. They're saying we already provide above that and we'll now stick out from everyone else, so that prospective residents and their families can see that we provide more staff than the minimum. The issue, of course, as Rob pointed out, was if I'm in a country town and there's only one provider, there's no incentive for me to put on any more staff, so I just meet the minimum. So there does need to be some guidance in there as well. So really, if I can look at the next slide. So what is the answer? Obviously, there's no single answer, as Rob said. There's no silver bullet. It's about a recognition of what care costs, recognising that expectations come at a price, and there needs to be a balance. And we need a system that accurately assesses the care needs of residents and provides guidance, a linkage to the appropriate number and mix of staff that's required. And it needs to take into account all of those variables. And what I'd like to leave you all with is a video that has a bit of an analogy for you, to show that just by pumping in 100 staff doesn't necessarily have the outcome that you want. If I could get you to play that.
Who made the assessment you needed 100 soccer players on the pitch?
Thank you very much.
You've given us a lot to think about there and something to laugh at as well. And we're getting now, because of the joys of the internet, people coming in online and asking questions. George via YouTube says, any thoughts on the role of technology to enhance the ability of lesser skilled providers to deliver services? And that's an interesting one, because that's something that we talked about at our last forum. I mean, but there are many forms of technology that are available, not just the camera. So is it possible that if we came back in 5 or 10 years' time and we knew what the best technology was available out there, that we could improve with the same funding, or at least, do better than we're doing at the moment with technology? Some thoughts, everyone.
I think that there's no doubt that technology that gives access to specialist skills, knowledge.
Have you seen something yourself that would work?
That are not always immediately available, will be incredibly helpful into the future. So that sort of telemedicine's already used extensively in country hospitals and health services to give access to specialist sets of skills. What I would say is that there is a baseline level of care, assessment, care planning and delivery that needs to be provided in the aged care facility, and no amount of technology will overcome that. So I think that technology might blunt the growth in demand, but it's not going to substitute.
Any other thoughts on technology? Rebecca, have you?
Well, look, we every decade we're doing things differently, and technology has obviously had a role to play. I mean, we're now seeing presentations done on iPads, and you know, perhaps as far as keeping records, you know, that will be valuable in the future. But nursing is a caring profession. I mean, it's a human touch profession, and I think that we need to value that more as a society. And I also think we actually need to value older people more as a society, and that is the crux of this whole argument. You know, we're talking about expenses, we're talking about costs, we're actually talking about Australian citizens, and I think that we need to reframe the whole argument, because I'm very pleased for my tax dollars to go to making sure that a person...
That was an interesting point, because, Rodney, when we were talking about the costs there and you were talking about where's the money going to come from, you were almost implying that people will pay for it. Well, I mean,
all of the survey evidence that's been done over 10, 20 years has been around would people pay more of a Medicare levy if that delivered more high quality...
Yeah, but it's like mutually assured destruction, though, because if one party says, I'll never put a tax up, and the other party says, I won't put a tax up, where do you get to that point?
But the question is, what do the public want? And the public wants safe, accessible health and aged care services. And they are prepared to pay for it, but they're not prepared to pay for wastage and a lack of accountability. So it goes back to Rebecca's point that we have to make providers accountable for how they spend the dollars, so that the punters like you and I actually know that the money's going to where we want to spend it.
And I just say, it's, you know, it's beyond tax. Yes, we get funding in from taxpayers, but there are other areas where we also get, you know, funding into the bucket, and it's a case of how we prioritise the bucket of funding. And if we are doing the best by people who are in aged care and they are in, you know, we as children feel comfortable with our parents in the aged care. We know they're receiving good quality care. There's less trips to the hospital, which is an expense. There's less ambulance.
Should the people, I mean, this is another question. I mean, we've actually heard, I'd like you to respond to what, because Peter put this forward. You've got these RADs, so when you go into the aged care home, that money goes into a big bucket over there. Now, it was bizarre, absolutely bizarre. At the Royal Commission, as I said, I sat there and watched it like Days of Our Lives. At the Royal Commission, when the RAD came up, the very clever QC, Dr. Tim McAvoy, at one point turned and he said to the person from the department, now, can I get this right? There are hundreds of millions of dollars sitting in these accounts, and what happens? And then they just said, oh, well, they're held there. And he said, well, does the Commonwealth get any benefit from the interest on these accounts? No, they get... Has anyone looked at any of this? You know, he was totally and absolutely gobsmacked that you could have $40 billion sitting there, and for all we know, the providers have got access to that.
The interest.
The interest.
Yeah, and the equity of it.
And some might be a provider that just says, oh, just leave it there and we'll put it at 2.3% because that's what the Commonwealth Bank is. I mean, that's the best you can get, you know, or whatever. They might be getting to it. Someone else might be saying, oh, no, I want to put it out on the hedge funds at Goldman Sachs in New York, and they might be getting 14.8%. We don't know. And I don't know that it's being audited. Has anyone ever asked that question? Because it came up in the Royal Commission, so it'll be one of the findings of the Royal Commission. But Peter is suggesting that it's a bit like a Medicare levy. It's a 1.5% of that money is taken from that RAD. You know, you'd take the 40 billion, you'd put it into the future fund or something. The future fund would...
It's a bit like the old training guarantee levy.
Sorry?
It's a bit like the old training guarantee levy.
That's your suggestion. Are we all nodding and saying Peter's on the money?
But
I was going to say you would need to ensure that you are able to provide that back to providers equitably, because you're going to get different facilities with different amounts charged.
Because some don't charge as high as much as the others. So someone get better training than others, all right?
Yeah, rural and remote areas would run the risk of being disadvantaged even more than they are currently if we didn't approach that.
And you'd need to have some checks and balances in it so that we don't have lots of in-house training that
Yes.
You know, there's a big
Variable
chunk
quality,
of...
shall we say.
Yeah, there's a big chunk of money that goes out of it, and you're really not sure as to you know how good that training is. And
All
look,
right. And look, just before I go to Moira again, any questions so far? I want to bring the audience back in. Yeah.
Undergraduate nurses to come on board, and we know the discrepancies between nursing in the public sector and so forth, but how do we encourage our tertiary educators, our TAFE educators, to actually value training in education and care of the older person?
Moira.
So they need to make those subjects compulsory, so they're not necessarily compulsory at the moment, and even our, not just our nursing workforce, but our unregulated healthcare workforce, and that's a whole other question about regulation versus an unregulated workforce, but they're not necessarily required to do training in dementia, and yet that's going to be one of the biggest areas of focus in the near future, and yet we don't even train neither our undergraduates or our aged care workforce in that area. I think also the point that Rob made earlier about you know, the majority of people that come into hospital are over the age of 65. That has been addressed to an extent with the introduction of the Comprehensive Care Standard in the National Safety and Quality Health Service Standards, which has a focus on older persons in that standard. But there's still a lot of work to do at the undergraduate level.
But industry still...
And sorry, I just wanted to ask Moira, have you got a presentation you'd like to deliver?
I've got some words that I can say. Some of it I've already done.
I know some of it you've done, but I mean, I can feel that you're at that point.
Yeah, sure.
Yeah, we'll come up and do that. And we've also got another question that's coming in online as well, so we'll get to that after that.
Thank you. And thanks for the opportunity to come here tonight and present on behalf of the College of Nursing. It is a great privilege. The Royal Commission into Aged Care Quality and Safety is shining a very bright spotlight onto our elderly community who are receiving care that is at a less than optimum level. The focus on how to strengthen the system to deliver aged care in a sustainable way, including investment in the aged care workforce to provide high quality and safe care, is in part what we're talking about tonight. Our ageing population and the focus on enabling our elderly to stay at home for as long as possible, and that's something that we do want to encourage, means that by the time people enter into a residential aged care facility, they are much older and much sicker than ever before. Of the more than 170,000 older Australians who are living in RACFs, a significant number are classified as having requiring a requirement for high care. The proportion of older people requiring high care for complex needs, and this includes things like assistance with all activities of daily living, including eating and bathing, has quadrupled from 13% in 2009 to 61% in 2016. Around half of the people living in aged care today have dementia, depression, or another mental health or behavioural condition. In fact, an estimated 60% of high care residents have dementia, 40 to 80%, quite a large number, have chronic pain, 15% have urinary incontinence, 45% have a sleep disorder, and 30 to 40% have depression. The management of these complex conditions and combinations of conditions requires a skilled workforce within the facility, supported by a strong multidisciplinary team, including doctors, allied health and specialist geriatrician services, and we will put nurse practitioners in there as well. A recurring theme in the evidence presented to the Royal Commission has been the need to invest in our registered and regulated clinical workforce to ensure care is overseen by skilled professionals. The view of the Australian College of Nursing is that this workforce needs consideration currently, and in particular Unlicensed healthcare workers, however titled, should be regulated. A registered nurse should be on site and available in the resident area at all times in residential aged care facilities, and notwithstanding that that's just one. Skills mix modelling should be considered when determining safe and appropriate staffing levels to care for older Australians. Resident care, as we've noted, is becoming more complex and unpredictable, especially for our vulnerable elderly, with all of the things that I've highlighted. Demand for care is also increasing. There are currently approximately 128,000 older people currently waiting for home care packages, according to the latest Home Care Packages Program data report. Wait times are over 12 months for people wanting to access a high level care package, and a proportion of these will end up in a residential aged care facility prematurely because they're not able to access a package, and their care needs are no longer able to be managed at home. At the same time as the acuity of residents is increasing, we are seeing less qualified, unregulated staff being asked to take on more and more responsibility with day-to-day care of our vulnerable elderly. With this context in mind, we need to understand that the provision of a best practice model is not as simple as mandating, for example, 3 staff on a shift. I think, Rob, you've already addressed that. Rather, it is about ensuring that there are the right 3 staff who have the appropriate knowledge and skills on that shift if we are to ensure safe and high quality care. This mix of staff needs to include at least 1 registered nurse on duty and oversighting the clinical care at all times, if we really want to truly impact and improve the care provided. Our health system and our aged care facilities are becoming increasingly reliant on unregistered carers with limited training, and this is negatively impacting on levels of care in all settings and patient outcomes. We've already talked about the ratio of unregulated workers. I think Rob's already highlighted that, and we've talked about the inverse relationship that's currently being witnessed in facilities. The College has previously called on the Australian Government to mandate the requirement for RNs. But in terms of the unregulated healthcare workforce, there are a number of issues that exist in relation to qualifications, training and regulation. This group of healthcare workers undertakes a significant proportion of the workload within a facility, and their contribution is valued, and indeed the sector could not operate without them. However, there is no consistent and agreed scope of practice. There is no agreed level of supervision required, or even a job title. They are known as multiple names across the sector. The view of the College is that this workforce needs to be appropriately trained, regulated and supervised in order to meet not only the needs of our current elderly population, but also the increasing levels of aged community members who will need quality and safe care in the future. The thought I would like to leave you with is that the new aged care standards have a specific focus on individual choice and control, and the need for facilities to truly know and engage with their residents in planning and providing care. It is this factor that needs to be considered when we talk about skill mix and workforce models. Nurses are highly skilled and proficient at delivering care. However, as our CEO, Adjunct Professor Kylie Ward, has previously written, it is the quality of humanness, how we as nurses humanise the health system by listening, advising and treating people with dignity and kindness, that is paramount. And this is what our aged care workforce must be able to provide to the most elderly in our communities. The resource of giving a nurse the opportunity to spend time with a resident is a key element in working to ensure that appropriate care is able to be planned and provided holistically. It is this ability and capacity to focus on an individual's combined physical, mental and emotional health which will mean the provision of safe quality care that ultimately leaves our residents happy and well cared for. Yeah. Thanks.
You raised some excellent points and remind us of some things that we've heard before, particularly the Dementia Australia evidence before the Royal Commission, which they said 50% of people have dementia in aged care, but then the University of South Australia study, which was done not long after that, said that the figure of undiagnosed dementia was as high as 25%, and then we've heard of those figures there of the number of people with depression, and I assume that they are not necessarily the same group with dementia. So when you're looking at it, you're probably looking at somewhere around the 80% of people in care. And that lady the other day that gave evidence before the Royal Commission sounded like she was the only one in the place. Remember the lady that was about 100? And she said, I'm sitting there at night and all I'm hearing is people moaning. And she said, it was very powerful evidence, and it reminds us that the frailty and the level of care that is there at the moment is actually only going to increase in the future. So I think we should come back to some of Peter's questions, because he did actually raise these at the beginning, and it was the Certificate 3 training needs to return to the classroom and return to apprenticeship-style training where skilled nurse educators provide teaching and where we have minimum entry requirements, including the ability to read and write in English, and then have to pass assessed criteria. Now, I mean, when you read that and you know what you've just said, I mean, we're all nodding, but whose responsibility is it to ensure that Certificate 3 training returns to the classroom?
So I'm currently, for my sins, Deputy Chair of the National Industry Reference Group that's looking at the aged care qualifications we were set up just a couple of months ago. So we've just released for industry consultation a new Cert 3 in aged care work. That's due to be approved by August this year. So that's stage 1.
How many months of training do you have to do, and how many hours of practical work?
There are no specific minimum hours of training. What we now have in the national rules is allowance for the industry and our reference committee to recommend new inputs for the first time. So that is allowed to talk about, can we do it all online or should we be doing face-to-face?
Do you think it's appropriate for someone to do a course entirely online?
Absolutely not.
Thank you.
So I don't believe in it, but it has happened over a number of years.
Well, I did hear of someone down in your electorate, Rebecca, and I tried to get her to put evidence to the Royal Commission, who said that she had 2 workers turn up one weekend, one of whom didn't know how to use a microwave, both of whom couldn't speak English.
And there are a range of courses being delivered around the country where the workers have graduated and never been in an aged care facility, never met an older person. And it's just insane that we should be delivering qualifications in that way. But can I say to you, the problem is also there in the higher education sector. We know that nursing programs are increasingly sending people to clinical placement later rather than earlier during the study period, and aged care placements tend to be earlier in the placement, so the nurses or the student nurses can do the least with clients. So then we wonder why, when they go to the high complexity, high technology placements at the end of their careers, and they get exposed to all that stuff as they're graduating, why they naturally gravitate to that area. So we do need to rethink, how do we organise the clinical placements, and the industry needs to step up to the plate in terms of providing opportunities for students at all levels of study to actually get exposure in the
All right, now Sue has contacted us online, and she says there is nothing arbitrary with the numbers and skill mix that is proposed by the ANMF.
Correct.
As Tony Jones would say, I'll take that as a comment rather than a question.
Absolutely, no. I think I made the point that it's evidence-based. It's not just a number we've plucked out of the air.
So I suppose then the question then is, if you've got a flexible, highly skilled workforce, you're not going to get them by doing online training.
Correct.
So when you see these things, they seem, dare I say, to be so glaringly, like, I mean, it was wonderful to get back to the Royal Commission again, but one of the people at the Royal Commission actually said, so then I take it is not beyond the wit of man to solve this problem. You know, it was a very Rumpole of the Bailey sort of moment, but he basically said, I'm standing outside looking on. It is not beyond the wit to solve the problem. It's not beyond us to actually fund the problem either, because even if you took something like Peter's suggestion of 1.5% of 40 billion, you're supposed to have done that number by now. What is it? Is it only 6 million? No, someone's better get their phone out and do it. It's got to be more than 6. 1.5% of 40 billion.
60 perhaps, yeah.
What is it?
I think Rebecca.
60 million. Would that go enough to, would that be sufficient to train enough people or not?
That's every year though.
Every year, yeah. a reasonable amount of money to increase training.
And it's on top of the
Can
existing
I just
investment.
quickly just go back?
Because someone's going to ask, how do you fund all
Can I
this?
just make the point that you made about universities, and universities have a requirement around English speaking, and they have to do an IELTS test. But I have heard anecdotally and on the radio recently that many universities are actually waiving that requirement to have a particular level of English proficiency, so because they get a lot of money from having...
Well, that's what the Four Corners was about last Monday night. The entire Four Corners program was about the fact that this university in Western Australia was simply saying, come on, come in, leave your wallets at the door, leave your academic credentials outside the door. And the academics were saying, we're going to put our jobs on the line, and they said they'll probably lose their jobs over it. Because they were actually, they were told, if you don't like it, this is the new way.
My pocket calculator says it is 6 million, so...
It's only 6 million, is it? Well, then it's not a lot, isn't it? There's not going to be enough.
1.5% of, how many billion?
1.5 of $40 billion.
Yeah.
Well, 10% of $40 billion would be $4 billion.
Yeah, so... But
Lucky none of us are the treasurer.
I know, this is the problem. See, we're all involved in caring professions and we need mathematicians.
But the point that Peter makes is well made, which is we need specific investment in workforce.
Yeah.
We need to get that out of renewable places, and we need to, I think the point that Rebecca made earlier, this goes on top of the existing spend, and the federal and state governments are already spending a shed load of money on workforce development now that is not well targeted, not well acquitted and not well spent. So we should get more out of that and add to it.
I think, you were talking about these online courses and yes, people can, I think, still get a Certificate 3 without ever entering a nursing home. But this does go back to cost, and I think that we also need to look at the fact that over the last 30 years we have eroded our TAFE system, which is where people would get a quality enrolled nurse qualification and Certificate 3, Certificate 4, and they're expensive, and people, you can't hex a Certificate 3.
Well, on that point, once again on the weekend, I think the Labor Party made an announcement that it would have 20,000 TAFE places allocated if they won office to aged care. Now, I'm not sure that's 20,000 a year. I assume it would be 20,000 a year, so there'd be 20,000 workers coming through every year who would be trained in TAFE. What would those people be then? They would be TAFE-trained Certificate 3 workers, would they? I mean, at the moment, the course is, how long does it take, the course? What, 3 months?
It's about, in nominal terms, it's about 500 hours of training.
500 hours?
In round numbers.
For Certificate 3.
For a certain
Well, that's 3 months roughly, isn't it?
So it
12 weeks?
It takes through a traineeship model, which I've heard Peter advocating, and I wouldn't disagree, that that's in many ways the best design model. That takes a minimum of about 10 to 12 months for delivery, with people going into study 1 day a week and then spending the remaining time in the workforce.
But isn't it also true that in Victoria they're paying for those courses to get the workers? I mean, that's my understanding, is that the Victorian government has done that.
Yes,
And
absolutely.
look, maybe that's...
We are here too. And we are here too.
Are we? Right.
Yes,
A state government is doing that, is it?
Apprenticeship and new traineeship money going out as part of the national program.
Well, I suppose that's a positive thing, isn't it? I mean, if you've got that being done. I think, though, the other issue that's come up tonight, which we haven't sort of looked at, is the idea that it is more complex than it is. I mean, this is why I think when the Royal Commissioner said it's not beyond the wit of man to come up with a solution, if we know that on average an aged care home has on average 100 people on average, and we know that that on average there are 80% of them have got problems on average, then you could actually come up with an on average answer to what you're actually talking about. So it's not, as the Royal Commission was told, it's not beyond the wit of people to come up with, an average speed limit, if you like, an average, we know that that's a safe level for that sort of level of road. We know that's a safe level of staffing. But what you're saying is if you mandate that, you've got a problem. If you don't mandate it, how do you do it?
If you just nominate the average and you don't link it to the categories of residents and their care needs in the sector so that it moves over time, keeps pace with people's needs, reflects the particular mix of clients in a particular nursing home, then you're buying a problem, because all you're doing is attaching one number to it rather than a system.
All right.
So
Well, we've got a limited amount of time left. We've got another 20 minutes to go. I'm conscious again of the audience. You heard the discussion up till now. It sounds like we are improving training. It sounds like we're thinking about training. It sounds like we're doing it probably better than it was in the past. I've been told, for example, that the other area that we haven't touched on tonight, which is home care.
I'm very happy to chat about that.
Which has got 128,000 people waiting for home care. But a person I know who works in that area said, as a home care provider, I want someone to come and work for me that has had a minimum of 3 months classroom and a minimum of 3 months practical. So they said it's got to be a 6-month trained person. And this person, by the way, previously worked in the hospitality industry, and he said there's no way in the world you would put, you know, a waiter or a person in hotel staff who didn't have 6 months training, and he said, I see aged care in the home having more in common with hospitality. In other words, how are you today? Would you like, you know, this? In other words, the person has to be skilled at human relations. You know, that's what he's looking for in home care. And I think the great nursing is also about how skilled you are at human relations. So getting something online, to me, just seems as if it's got to be outlawed, doesn't it? Really?
The issues we've talked about in residential care are even more risky.
Yeah, I mean, how could you have someone who's only done something online go into someone's home? The only thing they've done is...
In an uncontrolled environment. The residents' care needs, as we've talked about in aged care broadly, are going up and up and up. So we are, for the purpose of doling out relatively tiny bits of money, sending people with inadequate skills into an uncontrolled environment without supervision and support.
So perhaps we are conducting an uncontrolled, unauthorised experiment. You know, you said you couldn't do this because it would be completely unethical. But maybe the Australian aged care system is carrying out an experiment at the moment. We've got hospitals where you have people that actually have to be trained, and out here you've got another system where you're allowing people who have got very minimal training to operate, and you can compare the two.
And the evidence from the UK, where they set up a similar model in terms of social care, was it collapsed.
Was it?
After
Okay.
a certain number of years because of inadequacies in the system. So, sorry, Rebecca.
Well, I was going to say that the risk sits with the person who is receiving the service, the older Australian, but the risk also sits with the employee.
Yes.
You know, if you're sending someone into a home that doesn't have the skill set, that doesn't have the experience, both of them are actually quite vulnerable.
Yeah.
You have a vulnerable worker and a vulnerable older Australian, and it can be a recipe for disaster. What I'm concerned about is what I see as obviously the holistic issue is that we have 128,000 people waiting for these packages, which then puts more pressure on residential aged care, because if you become unwell while you're when you're not being supported in the home, you're more likely to end up in aged care.
You're more likely to die. 16,000 of them died.
That's
so
right.
That's
exactly
roughly
right.
10% of the people waiting died.
And
so
was in 1
that shows
year.
the level of frailty
Absolutely.
of the people on the wait list.
Yep.
Or they end up in the emergency.
Well, they end up
Yeah.
emergency, yeah. So in a sense, it's not great economics, is it? Unless you're a real bottom line economics person, where you say, look, if we leave them waiting, they'll die, and then we don't actually have to have them as a residential care or a home care patient, because we'll simply just leave them there for long enough, and that would be terrible if we were doing that.
So I've had 93-year-old couples who have come to me, and they've had the foresight to come to their federal member and say, we've been waiting for a package, we need your help to get us bumped up the list. But then there's all of the people who don't, and in that particular case...
And do they get bumped up the list or not?
Look, it's pretty
When you
magical
contact
once you do ring, and we have to push, we have to work very hard, but that's a, it's one of my top 5 issues.
It
shouldn't be like that, but as this elderly gentleman said to me, we're 93, If we're not entitled to a home care package, who is?
And they don't. They want the couple wanted to stay in their own home, not go into an aged care home.
And so they were trying to wash each other in the home, and one of them also had some cognitive issues, and it's incredibly hard. They want to stay together now. For that particular case, that meant with having that care in the home, and I think it was only maybe a Certificate 3 package that they were
Level
able to
3
get
package,
for one, for one of the two of them. It meant that the other partner was able to go back and still participate in bowls and a lot of other things, because we don't ever talk about the loneliness. I think one of the most critical issues around having making sure that we get the staffing mix right is that for many people this is the only person they're talking to all day. You know, the family are coming in once every few months, dropping in at Christmas, maybe dropping in for a birthday, and then that's it. So there is such a vulnerability with older Australians that I just don't think we're having the conversation nationally about.
And I think that then brings us to the to regulating that workforce. So that at the moment the Certificate 3s and 4s are what we call an unregulated workforce. So registered nurses and enrolled nurses are required to register with ACMA, with the Nursing and Midwifery Board of Australia, and their practice is scrutinised, regulated. They have a tribunal sitting over them. They can be reported. The unregulated health workforce, so our 3s and 4s who are doing the bulk of the heavy lifting and doing most of
Can I ask you this
work.
question? This is something I've always wondered. Can you simply just turn up at an aged care home and say, look, I haven't got any certificates, but I'd just like to work here, and can they employ you?
Yes.
Yeah, because I have heard that.
Yes.
So when you say unregulated, at least Certificate 3, there is a sort of a certificate, but there are some people that haven't got nothing at all other than just the desire to work in an aged care home.
And another risk would be that you could have a registered or enrolled nurse who has had a condition placed on their practice, and they have been virtually struck off the nursing.
But they can come back as a worker.
They can come back into as a worker in the aged care workforce.
So I suppose there's a lot of levels of concern there, and I'll say this to everyone here again tonight, that the interesting thing about the Royal Commission is, as it's been rolling along, they originally said that they would cease the number of submissions they received by June, but now they're saying they're going to keep going. And I think some of the things that you've put forward tonight, if you haven't done so already, I'm sure you probably have, but if you haven't done so, I'd say put them into the Royal Commission, because all of that material, it goes in and it sort of gets synthesised and it's coming out in these interim reports. I know they've got a special interim report in October, but they've got these background papers that they've been putting out at the moment. I think the better informed, and this is why something like tonight's great, because it's another level of discussion and education, and hopefully it'll go into the Royal Commission as well.
I think that the other thing I'd say about home care that's the real sleeper is that currently, depending on which category of home care package, you get a bucket of money. Now the consumers and their families are then left making the choice about what do they buy with that pre-approved limit, because sometimes you're making a choice between an unqualified and unregulated worker who will give you more hours than someone else who's got the knowledge and skills designed to meet your needs. And that's a really unholy recipe for a system, that we're asking people to make decisions about their care based on the envelope of money and not about their assessed needs.
I might just add to that. Firstly, I announced last week that along with reintroducing the bill that I wrote last year, I'll be introducing legislation for a national register for care workers, because you talk about that person that arrives, would really like to work for you, you just don't know
who they are.
What their background was in, perhaps they were let go in previous places, and we've had some cases in the Royal Commission. And again, it's just about making sure that we have those safeguards there for all workers, because I want to see this whole profession as an esteemed profession, and one where people feel protected and supported. And I think with respect to home care packages, I think we need to look at what I see as some real concerns. The fact that I've had constituents say to me, I want to move providers, I don't like the provider I'm with, I don't feel that I'm being valued and I'm getting the services I want, but they're going to charge me a $500 exit fee. Or they charge me, upwards of 20% administration costs. So I think there's some price gouging that we need to look at and some rorting, and I think that we need to look at that right across the continuum. And I think that we don't value the CHISP funding enough. The fact that
Sorry, which funding?
The community home support services. Because again, when you're looking
community
at
home support program.
Exactly.
Yeah.
When you look at, and there's sort of it's always faced the act. Well, it's been facing the act since the introduction of the My Aged Care. But we know that that's the program that really supports
the majority of people use more than residential care, more than home care.
Exactly. But that program often stops people from then needing the other supports because they're getting out, they're socialising, they're getting some home support, they're not climbing ladders to clean out gutters. There's some really good supports.
It's interesting you raised this because I wanted to just bring this up because this sort of shows you what actually is happening on the ground with 90-year-olds. I had a woman contact me today and she said, I'm writing to you regarding a change to provider arrangements for the services you receive under the Department of Veterans Community Nursing and Veterans Home Care Program. Your current provider, Bolton Clark, also known as RSL Care and RDNS, has informed the department they will be withdrawing from providing community nursing and home care services for all DVA clients nationwide as of the 30th of June. So I've got a woman contacting me and saying, well, who's going to look after mum? She's only just got used to this person washing her. And, and like mum's probably got, a bit of cognitive trouble. She probably doesn't like, someone coming in and washing her. She's now got this person. She's finally got there. And then she gets this. And she's on to me and saying, well, Ian, what can you do? And I said, well, look, I work for National Seniors Australia. We advocate at that level. This is advocating for your mother at a personal level. You need to go and talk to the people and express your concern. They talk about consumer-directed care. Your mother wants the same woman to wash her. That's what she wants, Anyway.
And see your federal MP.
So see your federal member. But
Absolutely.
But it's interesting that all the things we talk about are, we talk about theoretical things, but on the ground, in that lady's home, the big question tonight is she's going to be saying, well, Mum, you may have someone you don't know who hasn't even been checked who's going to come in and wash it. We don't know. And that's not good enough. That's not good enough for a war widow.
That's right.
It's not good enough for whether they're a war widow or not. But she's getting letters from the Department of Veterans Affairs saying, look, as of the 30th of June, that's it. You're in another world.
Exactly the same argument as we've just been having around home care packages in this space, which is you've got a federal government department that's doling out a bucket of money that does not have a relationship between the care and the support that's needed and how much it costs to deliver that care. So you've got providers walking away. In the same way as they are in the disability sector.
But they're walking away on the 30th of June, so, I mean, we're almost mid-May, and on the 30th of June, she doesn't know. And then they have some sort of reassuring note on this letter which says that, it's a bit like the lady you get from My Aged Care, where it says, please be assured that we will continue to provide the same level of service and care for you as we have in the past. And she's saying, well, how can they? How can they? Because it won't be, Jenny who's come in and she's got used to, this 93-year-old lady. And I think we do have to remember that it is about human beings, the relationships between human beings. We are social animals. We don't want to be numbers. We don't want to be using portals and all of that. And I think that's I mean, we get people all the time saying there are 2.5 million Australians that are not on the internet. 2.5 million Australians, they actually want to talk to someone. Now, I'm conscious of the time because we're 10 minutes before time. Now we've got another comment coming in from the interweb. Given most providers have boards, why haven't the boards stepped up to tackle this issue? Most boards are not having these conversations, they're sitting around waiting for the answer or to be told. That's a very interesting question, isn't it? Because a lot of I wonder what the RSL, or whatever it's called now, is actually how you would walk away from from that? I mean, there must be a bigger story there, but I mean, and this other issue of the providers who've got boards who haven't stepped up to tackle these issues. I mean, do you think that people that are on the boards of some of the aged care homes at the moment are saying, look, let's not get too political, let's not get too... What are they doing?
I think that we need to be mindful about what boards are responsible for. And the number one purpose of a board of management is to manage the business and the organisation's survival.
Not to worry about the political picture.
They're not there to reflect on the individual care that client X, Y or Z receive, or whether the political system is right. They're running the business. And if they don't do that, they're in trouble in terms of their licensed role in the world too. So I think we've got to be a bit careful about how much we ping on the board. That being beside, that's where the purpose of regulation by government comes in, to say to the boards, you need to be accountable for these things as well, which is standards of service. It is about the interventions and it is about the staffing requirements. That's why the mandatory minimum stuff comes into play there, because it imposes an additional legally binding obligation on boards and on organisations.
Right, now I'd like to bring the audience back in again. So there's so many of you out there. I know, but I do realise that there are a lot of people watching this online as well, because this is why we're getting all these questions coming in. But just before we get to your question, you've heard the argument tonight about the blunt instrument, and we've heard the argument about mandating staffing levels. Just as a quick show of hands, have you come tonight with a view that you wanted mandated levels and now you're thinking again? Can I have a show of a hand if anyone has changed their view slightly? Good. What about the other way? People that came along thinking, actually, having heard the arguments that have been put forward, that I think there should be more defined levels. You know, okay. So there's a slightly more the other way. So people are still wanting, because when they do that's pretty actually accurate, because when they do the surveys, it comes out at about 80-85% of people say, look, you know, it's like a swimming pool. You have to have so many lifeguards per the number of kids. It's like a daycare centre. You have to have a certain number of daycare workers for the number of people. And this is the way people see it. But anyway, it's interesting to see that. And your question there, can you say where you're from?
We're from the United Kingdom, so
good.
I'm sitting here as an observer.
Welcome aboard. Congratulations on the baby. Yeah. You have royal babies, we have royal commissions. Come on.
Royal baby's not really something I'm interested in. So.
Just bring the mic up a little bit.
Okay. Well, firstly, it was very interesting for me to hear 4 compassionate and knowledgeable individuals talk about this, so thanks very much for that. But there's one thing that we focus on a lot in the United Kingdom that really wasn't mentioned tonight, and that's recruitment. So there's ideally, I think, to solve a lot of the problems, there would be a compassion and empathy meter that we could just look to see if someone actually cares, because that's the biggest problem in care. I think some people don't care, and they're the people that give the whole sector a bad name and sort of drag it down in the public image. And another thing for us is a service well led? So our regulator, we have very tight regulatory frameworks. I'm not saying it works perfectly because it's very often flawed, but one of our key lines of inquiry for the regulator is the service well led. And I think well led doesn't take into account the things that actually matter.
Bring the mic up a little bit, sorry.
A service being well led doesn't take into account the things that actually matter to the staff that are doing their jobs. They don't get any thanks, so it's a thankless job that they're doing, and very often an underpaid job, very difficult. So we operate challenging dementia services, and very often there's very physically aggressive residents in that home. And I've seen a lot of our staff being physically attacked by residents, but at the end of the day, do they go home thinking, I feel valued by my manager, by unit managers? And I think it's something as simple as thank you or good job today, and that doesn't cost a lot of money for care providers to do, but it will make a big difference to how your staff feel and ultimately how those staff perform. That will in turn improve the lives of the residents that we're actually caring for in the first place. Yeah. So I think we overlook the simple changes that cost very little, but will make a huge difference to the quality of care that we're actually delivering. To me it seems strange that staff are unregulated because we have very tight procedures around recruitment and monitoring that we have for staff. So I think there's so many changes need to be made, but simple changes that make a big difference. We don't often talk about them.
It's fascinating you should say that about the, there have been a lot of research studies which show that people will stay in jobs regardless of the money if they feel appreciated and they feel cared for and they feel respected and they feel... I even heard Steve Jobs or whatever saying that when he was working at Apple, these other people used to come along and try and take them all away, you know, because they all wanted the brains that were at Apple. But they had that sort of thing where they felt, you know, they were part of this thing that was doing good, and they were at the forefront, the cutting edge. So they could come up and offer them another 100,000, but they'd rather get a pat on the head from Steve Jobs or whatever and said, you know, you're doing well. It gets back to that human dimension again, doesn't it? And then the other point you made was about recruitment. Do you do something special in the UK that we could learn from in terms of recruitment?
Like I said, if you could tell if someone cared, that would be the best solution.
But do you test people for that at aged care homes?
It's very difficult to do. I mean, we put together detailed interview procedures, and we try and target questions that'll try and delve into someone's
But you spend a lot of time on the recruitment. Recruitment is critical.
Yeah, recruitment for us is a huge thing. You know, not qualifications on paper is one thing, but you can be the most educated person and qualified in that service and still be nasty. You can still do something very nasty, regardless of qualifications. It's hard to do, but it's targeted questions that look at how someone responds in a stressful situation to try and gauge their empathy. I think that's something that we should
It's also, you made the point about leadership.
Yes.
And if you are leading an organisation in a way that lives those values, then you're going to be more likely to recruit and attract other people to the organisation that will practice in accordance with that value. There's lots of evidence from the magnet health system in the US and overseas around leadership, quality, focus, devolved and engaged structures, so making sure leadership's close to the point of delivery, that we're engaged in staff development and workforce development, professional practice, and ultimately we're also engaged in personnel practices, including the money. It has to be said at the end of the day that will value and recognise the contribution of staff. So, I mean, I think it's a mix of all of those things. But what we do have, I think, in aged care across the country, although there's been a huge growth in big corporates more recently, is still a cottage industry approach to leadership and management.
Well, do you think this is a big one to throw out at about 3 minutes to 8 when we're supposed to go home, but do you think it actually should be a profit-making sector?
No.
I mean, and it's a fascinating thing, because if you do say yes, then I always come back and say, all right, well, if that's the case, what's a fair return on investment? Because you've actually got a closed market. You've got a completely closed market, and you're being accessed to a closed market and being given government money. So there should be a return on investment in the same way as, I don't know, I mean, it was 30 or 40 years ago, it might have been 30 years ago, when Melbourne decided that it couldn't run its trams anymore, and they gave it over to somebody or other, and they said, right, well, you run the trams, but we know how much it costs to run the trams, so you'll get X amount, you know? And they did it with South Australia with the electricity. They said, well, you know, you'll get the electricity for, I don't know, 200 years, you get the rights to run the electricity market, but you'll get X amount. I mean,
I'm not sure how well that's worked out.
I know, both of those probably haven't worked out well. But if you are asking capital to be invested into an industry and you see it as an industry, then I suppose you've got to say there's a return on investment.
And I don't think you can criticise it. And I think that's the problem that we have, is that everyone is very quick to criticise the for-profit sector in particular.
Often they do a better job.
But the for-profit sector is there because they were invited in, and you can't invite them in and then say, oh, you shouldn't make a profit, because a for-profit makes a profit.
But I've also seen for-profit sectors actually do very well in some areas.
But we are seeing evidence of, and the parliamentary inquiry demonstrated it, of tax avoidance practice by big corporates. That
was raised up there.
Ripping off our money, taking money away from client care and pocketing it as offshore profits. Now, those are the sorts of practices that just should be completely
Well,
outlawed.
that's up to Rebecca, you see. It's up to you.
Well-
You've got to fix this. You see, you're the only, you know, they talk about the elephant in the room. You're the politician in the room.
Thank you.
And if you get re-elected, seeing you're the only one that turned up tonight, we're going to hold you responsible for the future of aged care in Australia, home care, and
I'll be leaving now.
And if you sort it out, I imagine given you've got the oldest electorate in Australia, you may end up
Sounds true.
like Tom Playford. I think he'd served for 32 years, 323 days or something.
Yeah.
Tom Playford served that long. And you know what the joke was at the end about Tom Playford, to talk about the idea of public service in the old days? Tom Playford apparently said, you know, that new Premier coming in, he's in for a bit of a shock. And everyone thought, oh, you know, what's he saying? And he said, because you see, back in the 30s when I became Premier, I thought I should only get the same amount of money as the rest of the team. So I've only got the same as a normal, you know, politician. He said he's going to be in for a shock if he thinks he's going to get any more money. I mean, that was the idea of public service 30 years ago. You weren't doing it for the money. You were doing it, and that was a bloke that was in the trenches in World War I. So I mean, that's a sort of, it's interesting to remember that there are people still involved in public service who do it for that, and there are people that are involved in aged care and all these industries because they love people.
Yeah.
And I thank you for coming out tonight, because obviously you love people. You wouldn't have been here. You'd be at home, you know, watching who's going to get married next or whatever the latest piece of, you know, stuff is.
Are you all going to give us 30 seconds as on an end thing to say?
I think you should all be given 30 seconds. I think you should be given more than 30 seconds. I think you should be given probably a minute. But you've got at the moment, yeah, I reckon we'll have 30 seconds. 30 seconds. Starting at the, we started at this end, so we can start at that end. 30 seconds.
I mean, I think that, as I said at the beginning, the mandatory staffing and skills mix is not the sole answer to the problem, but it's a fundamental ingredient of the answer to some of our problems, along with some of the systemic reform around leadership, accountability, transparency that we've alluded to tonight.
And look, I think that we have to stop oversimplifying the workforce issues and just looking at sheer numbers, trying to get more and more numbers in. It's not the numbers that count, it's the actual individuals and their aptitude to care for those.
Going back to your wonderful visual analogy, if you had 4 really good footballers on the field, they could knock off 100 others. But in caring, it is actually you still do need.
It's a mix. It's a mix of numbers and skill.
Yeah.
And it's not just a simple equation.
Simple. Yeah. All right. And Maura?
I just think we need to focus on the clinical leadership within a facility that a registered nurse brings.
So good leaders in the aged care home and in the aged care home providers. That's really good leadership.
Yeah, that can facilitate that culture that will focus on caring as core business.
And I want to see the aged care minister, the next aged care minister, to actually be sitting within cabinet. It is too important a position for them to sit outside the cabinet room and hope that they get some money come through the door.
And I want my 30 seconds is to say that I really appreciate the fact that people do care about this, because I know that we're all going to be there at some point. And in the words of the late Professor Graham Hugo, who was quoted in the paper on the weekend, we know that the baby boomers and the generation below our parents are 8 times more likely to have 3 or more comorbidities. So in fact, we are not getting healthier and better as we get older down the track. We're getting frailer and need more care, and if we don't care, then someone won't care for us. So even if it's just out of pure self-interest, when you're talking to your friends, when you're talking to the politicians, whatever, you say, look, if you don't get it right, you'll be there sooner than you think. I mean, I could have a stroke when I walk out of here tomorrow, tonight, and tomorrow I could be in an aged care home. And it's happened to people. I saw a lady at the Royal Commission, she gave evidence like that. So I think it's really great that you've come out tonight. I think you deserve a round of applause for trying to improve things, and thank you to all our speakers tonight. And Peter is there. I think he's probably under anaesthetic or something. Last time I was referring to this a few times, but he was still sending information. You say you can't keep a good man down. The last time he said he was on a trolley about to go in somewhere. Anyway, but but I'm sure on behalf of Peter, he'd say thank you very much as well for coming along tonight, and he'd say thank you to his wonderful family for helping out as always too. Yeah, and also the others that were here tonight. Thank you very much for doing everything. And you can network now, you know, you can have a nice look. There's some lovely cheese and biscuits out there. We can all have a nice Chardonnay. Well, just remember, not having that cheese and biscuits and that imaginary Chardonnay is probably going to, you know, make you live a healthier, longer life, you know? Yeah. Did you know that whole thing about one glass of wine a day, they've now come out and found out that any level of alcohol is supposed to be not good for you. Oh. I know, it's terrible. There's another study. But there's a study. I mean, yeah. Thank you very much, Rebecca. Yeah, no worries. I'm still in a job. Yeah. Well, the bookies are saying you're